Good morning, everybody. I'm Dr. Rebecca Griffith, the ED-DPT, and welcome back to another episode of Admitted or Not, the pod/videocast. And just a disclaimer, it is summer season here at the Griffith household, so this door may come bursting open with loud, exuberant children in any various stages of distress or happiness. So we're just going to roll with that if that happens. And today I have with me Dr. Lisa TenBarge.
Well, hi, everyone. I think the chaos in the Griffith household fits well within an ED discussion, for sure. Like Rebecca said, my name's Lisa TenBarge. I'm a physical therapist at Flagstaff Medical Center. If any of you saw the interview that Rebecca did with Taylor Bush, she and I work together. So we are located here in Flagstaff in northern Arizona. Flagstaff Medical Center is a level 1 trauma center. And we've been practicing in this, I've been practicing in this environment since 2004.
So I just want to throw this out there, and I know you're not necessarily comfortable with this, but I think you're an absolute legend in the field of emergency physical therapist practice. And I told you were just going to have to own that legend status. But you're truly one of the pioneers of this field of practice in physical therapy. And so I'd like to hear your perspective about like how this got started, what barriers you faced, and like how you've seen things change over the years.
Well, to start, I think, I think all of us sort of stand on the people that came before us shoulders, and that's no exception for me. I was in 2003, in the fall of 2003, I was attending a state physical therapy association meeting in Phoenix, and there were a couple of gentlemen presenting at the state meeting, Mike Lebec and Mike Andreas, I believe is his last name. And they were working in the program in Tucson, Arizona at Carondelet. And they had been going for about 2 or 3 years at that point. And just spoke about like how that program was working. And they were one of the few in the country that were doing it at that point. Michael Brickens, I believe, was also starting a program in Indianapolis at the same time. And so they were I listened to him talk, and my supervisor was sitting behind me in the classroom, and I turned around and I said, "Why aren't we doing this?" This should be something. At the time, I was the lead for the outpatient department. And what we would find is every now and then we'd get these dribble in patients from the ED that were appropriate, but it had maybe been several weeks since their ED visit by the time we saw them. And so we would go over and maybe talk to the ER group physicians every now and then and say, hey, send us your patients from an outpatient perspective, send us your patients when they are appropriate. And this seemed like a very natural next step. So we, Lori Perlmutter was my supervisor at the time. We came back and sort of had a powwow about what that could look like. And we did a presentation to both the administrative group and the ER physician group to say, and what we did was I modeled, I went down and did a day. I did an observation day down in Tucson with the guys. And as in true ED fashion, they didn't have a single patient that day.
Of course, figures.
Weird. It's just the way that is. If someone needs to see it, then yeah, it's always like that. And then it'll be the next day with like thousands of people.
Right.
But what it did do was it gave me a lot of time to talk to them and sort of pick their brain about what they were doing and what the process looked like. And so we just put together, I got some numbers from them on patients that they saw and typical interventions and just presented that to our group. And they said, okay, that was in February. And they were like, okay, do you want to start in March? I was like, okay. So that's what we did. We started with 2 of us doing just managing 7 days a week. We decided to start it at a 7-day a week and not and an 8-hour, 7-day a week program. We just assumed that if you build it, they will come kind of thing. And so rather than what we found was, in talking to them is the on-call thing the paging system thing didn't really seem to work as you were starting a program because you don't have enough time to do the education that needs to happen for the providers so that they know what are the benefits from having physical therapy in the emergency department. So it really did take that initial time of just training and education to get us up to speed with the providers that were already there.
I like that you just started with 7 days a week. Like we had to move up to that, and we just finished a new pilot program. And then the next question is always well, are you going to do this on weekends also? Because as many ED physicians have said to me, Sunday and Monday are no different to them. There's no difference.
And for a lot of EDs, it's some of the busiest days that
right. Because there aren't a lot of other resources.
Absolutely. And in this environment, this is a very transient kind of city. We're right in the middle of, 90 miles from the Grand Canyon, and where two major, highway intersections meet. And there's a lot of transient traffic, and summer is super busy. Winter is super busy. And so the need, especially on weekends, it was great. So
yeah. So what hours did you start staffing?
Well, we originally started a little earlier in the day because what we did was we went and looked at the data, all track data, mine data. And so we looked, when are they the busiest? Because it doesn't make sense for us to not match their busiest times.
Right.
The assumption is if there's a bell curve and we're in the middle of that bell curve, that's going to hit the patients that are the most appropriate for us. And it didn't, we get jokes about us having banker's hours and not, being 24/7 like they are. But yes. The reality is, people don't come into the ED with physical therapy complaints at 2 a.m. They, they're coming in with heart problems and abdominal pain and things like that.
I always joke that nobody wants to do physical therapy at 2 a.m., especially the physical therapist.
It's so true. That's so true. Very true. So we just sort of looked at their data and tried to match that. So we started with a 10 a.m. start time because we had an 8-hour window. And so we started from a 10 to 6:30 type of, but what we found was there were lots of patients that were coming in around the 5 o'clock hour, and that 6 o'clock end time just didn't really fit very well. So we kind of quickly shifted, probably within a few months, to 11 to 7:30. Time frame, and so that's what we do 7 days a week.
Still
7:30. Yeah, still
awesome.
7 days a week. And the other thing that we initiated probably about 2 years ago now, got thrown off a little with COVID, but was something we call an early AM ED program. So the acute care staff, because we don't come in until 11, and frequently what's happened is sort of overnight, they've got these patients in that maybe don't meet medical requirements for admission, but for whatever reason can't go home. So they mobilize, but they don't have any medical things that will keep them there in the hospital. And so they are held overnight sort of for therapy assessments for potential placement. And so what we found was they having to wait until 11 until the ED therapist came in was not really functional. So we did a little up training for the acute care staff, which actually they didn't need training in how to assess the patient. They needed training in how to manage the ED setting, but training to get them, how to manage that process. But then, so each morning, so we just do a calendar every month of the early AM therapist. So there's someone assigned every morning from about 7:30 to 11 to cover any of those types of patients. So, and that has seemed to sort of bridge the gap a bit for being able to not have a patient waiting an excessive amount of time to get seen.
That makes sense because it is an issue. I mean, we will often staff 9 to 5, things like that, but sometimes patients are sitting there waiting, especially if you walk in and there's 8 that have been holding overnight. That can be a huge problem.
It happens.
And then how do you get caught up? Because if you walk into 8 and then patients start coming in, it can be a real big issue. Do you also find that you have an issue with patients that are boarding in your emergency department still, or has that been kind of improving?
Frequently? Yeah, no, that still happens. And some of it is seasonal, but really it's kind of a year-long thing. And some of it, especially in this season with nursing staffing being so difficult, that is sometimes the problem where the patients aren't moving through. So they're housed, but they're admitted, but they're still housed in the ED. And so what we have sort of taken to doing is for those patients, rather than being assigned to a floor patient, we sort of have them on our radar. And then if they're appropriate, we just see them in the ED to get their admitted therapy plan and discharge planning started.
Yes. Yeah, I think that's great. I think if things continue the same trajectory that they have been, we may need to, in every ED, just have a patient or a PT that's managing the patients who've been admitted, but don't have anywhere else to go. Because that's a whole different zone. And sometimes the ED therapist really can't do that and the new patients that are coming in.
Right. Yeah, it totally makes sense. And so the therapist now, if they're not, because you know how that is, the patient load really fluctuates. And so what we have done to just manage productivity to some degree is we, as a rule, the ED therapist gets assigned a floor patient or two every day, sometimes 3. The other day I came into 5. So it sort of depends on the day, but that helps us sort of manage slower times in the ED, or they're, frequently we have, like most emergency departments, I think now are kind of back up and running with sort of a fast track or an urgent care area beds that are designated for those lower acuity patients. But ours used to start at 11 and it doesn't start till 1 now.
Oh.
Have this kind of 2-hour, gap where sometimes they're sort of holding, waiting, or they're, the normal fast track flow doesn't start until a little bit later. And so it's easier for us to then manage the housed patients in the ED or go see floor patients if we're needing to kind of balance productivity for the day.
Makes sense. Okay. So tell me then, with nearly 20 years of experience practicing in the emergency department, what have you seen change? What do you still want to see change?
I think the most challenging thing for the emergency department physical therapist, probably over time, if you are in the same place for a long time period, is the turnover. It's just the nature, I think, of that, where you get a lot of turnover with nurses, even turnover with physicians. I think there are probably a few physicians that were there when I started that have all kind of come on. And there's benefits and drawbacks to that for sure, because I don't know, newer staff bring new ideas and maybe sometimes a little more open to new thinking and things like that. Or maybe if they're coming in and they're a newer ER physician, maybe they've even heard of having physical therapy in the ER before, where when I started, no one knew about it. And so that's a real benefit. The challenge, I think, is just that it feels like you're sort of constantly marketing. Mm-hmm. Constantly talking about the benefit of physical therapy, because it's just not, I feel like I've said it 1,000 times, and yet there's somebody new in there today that's a traveling nurse that has never heard of physical therapy in the emergency room. So it feels like sometimes kind of a constant marketing push, which is okay. I mean, it keeps it fresh. And I think it's fun to me, especially with travelers now. I think one advantage to that is that they're going to do a rotation here, work with a physical therapist in the ED, and the next ER they go to, they're like, "Hey, how come you don't have physical therapy?"
Yes, that's the goal.
I see it as a benefit to us as a profession and as a growing, practice environment.
I think that's particularly the case in teaching hospitals, where your residents are turning over pretty frequently. You're getting new attendings, new fellows, interns, medical students. I can remember Michael Brickens in Indianapolis, because theirs is a teaching hospital that has that exact scenario. And I remember him, this was probably, 15 years ago, talking about that. And I was like, oh, wow, what a drag. That's too bad. And that's exactly what I'm doing now all the time, which is just, I felt like I was in a little bit of a bubble in those first few years, because it was just the nursing staff didn't turn over, the ER staff didn't turn over, and it was this little bubble of consistency. But that's not really the nature of this practice environment, I don't think. Yeah, I agree. So tell us, what's your elevator pitch then?
I have a few tacks depending on who I'm talking to, but I would say in general, knowing that, understanding that you are not used to this practice environment. We are musculoskeletal experts that can assist with all manner of patients, especially orthopedic, and especially what I ask them to think about is all of the non-fractured orthopedic patients that they see. Almost every one of them can benefit from physical therapy in some way. And they don't think about that. Like they think, okay, non-fractured orthopedic patients, they're going to just send them to ortho and then on with the rest of their day rather than, and when I say, when you send them to ortho then sends them to therapy. Why not?
Right.
Let's bridge that gap and get that early interventive piece going now. And most of them also don't realize that we have some skill set for and some training for vestibular patients and wound care patients. So there's usually try to throw in a little bit of that too, especially for the areas that I'm sure they don't think of using us for.
Right.
And talk about just improved outcomes, faster return to work, things like that.
I think it can be really difficult to communicate everything that we do effectively and concisely. Mm-hmm. So I found that beyond that wonderful elevator pitch, it's probably you showing them what you can do more than anything else that makes a difference as opposed to just what you tell them, right?
For sure. And I can remember when I very first started, one of the ER physicians really kind of hounded me for a while on cost. They were like, why do we want to add additional cost to patients? The ER stays are already so expensive. And I thought about it for a second. I said, well, I think that one of the things that, you don't question, like if you feel like someone needs a lab test done, or you feel like someone needs an X-ray or imaging test done, you don't even consider the cost because you know the value of what that test or procedure brings. And so my job is to help educate you on the value of physical therapy, because understand and know that value, you won't question the cost of what that like. And by the way, it's less than an X-ray.
100%.
Let's just go there. But, but the bigger picture is you don't question what you value, right? When you understand the benefit to the patient, you understand the value, then the cost is, you understand that cost benefit ratio.
That makes a lot of sense. I really like that approach, to focus on the value and not the cost.
Right.
So I know
there is a cost, and that's a real thing. And you do really have to make sure that patients are aware of that, because it's still not a standard practice that is, and so as a standard of practice, we always make sure that people understand they have a choice.
Yes.
And, here, I'm here, this is what I feel like I can do. Is that okay with you? To give them the option to say no. And I have had patients say no, not very often. Once they understand, or once I've explained what I feel like I can do for them, then it's very rare that they say no, but every now and then.
I think that's fair. We've only had, I think, like one complaint about the cost of physical therapy in the emergency department the whole time that I've been there, which is great, which means that patients are either their providers, their insurers are paying, or, they're still feeling that value benefit to what we're doing.
And I would say the same. In the length of time I've been in there, 18 years, I've had one person but they weren't just complaining about the physical therapy. They were complaining about the entire cost. It wasn't isolated to us.
Yeah, this particular case, the patient was trying to get anything off the bill that they could. And I think that's totally valid based on how expensive healthcare is. I probably would try to take the same strategy if I really wasn't able to pay the bill. So I know that you're a big advocate of having students in the emergency department and sharing this mission with students, but tell us a little bit about how you make sure the students are well prepared for this.
I so encourage, every program to initiate students in some capacity, even if it's they're doing an acute care and outpatient rotation, but you have physical therapy, even on call, bring them with you, like just get them exposed to that environment, because it's so important. And so many students, I think, once their eyes are open to the possibility, are very intrigued by it. But the reality is it's a very intimidating environment. It's a very chaotic environment. Not everybody does well in those environments. So one of the things, and it is really practicing at the top of your game. I feel like that there is there is a high expectation from practitioners that you are very comfortable and competent with differential diagnoses, and again, that you'll bring value in an efficient way that's not slowing throughput. And so that's a high challenge for students. It always has been. Even when they're really good, it takes a while to get comfortable in that environment. So some of the things that we do is we actually ask for a faculty recommendation specific to the kinds of skill sets that are valued in the ED, with high-level thinking, diagnostic, maybe not experience, but the ability to kind of think through a process and be able to give valid justification for their thoughts and really ultimately, because at that point as a student, they're not going to have tons of experience that way, but their communication skills, really have to be kind of top notch. They really have to be the ability to speak through not that I'm doing that eloquently at this moment, but that you can speak through your thought process to a physician and have them understand what you're saying, that you're not using a lot of, jargon, and that you're speaking at their level, and that you're speaking thought processes that make sense to them. So communication, so some type of letter that gives us an idea that the faculty has confidence that the student will succeed well in this environment. And then we ask for a letter of intent from them as well, like why they want to do it. And it just, there's no right or wrong answer to that. It just helps give us a little bit of insight as to what their motivation is, what they maybe hope to gain out of it. And that can help us sort of direct whether or not they'll be a good fit. And then the other thing that we do is we require a phone interview.
Okay.
And so that also is an attempt. It's really because the environment is it's challenging, and it can be really stressful, and we want students to be successful. And so that it's an effort, it really is just an effort to try to figure out, are there any things that might indicate that they might struggle in this environment? Because the last thing you want to do is bring a student in that then really struggles and then is not successful. Yeah. So we found that putting those things in place helps us. I think it's not foolproof. It gains us students that are really successful, and sometimes it gains us students that struggle and still struggle in that environment. But for the most part, I think that's been a fairly successful approach.
I think that makes a lot of sense, that it shouldn't be just any student. I also think it should be a student who's, like you said, interested. Because if this is not the kind of, if you like predictability, if you like having long-term relationships with your patients, if you're still in that clinical mindset where you need to see it through all the way to the end, and that you don't understand the arc of how this patient's process is going to go, it gets very difficult for students who don't have that insight yet.
Mm-hmm. Agreed. Yeah, it's very true. I think it's definitely one of the challenges of working in this environment is you don't get that follow through or throughput, but you do get this, just because you're inundated, it's all evaluations. You're thinking diagnostically all the time.
Yes.
I think that and having some background in outpatient, that is one of the other things that we do require is an outpatient rotation prior.
Okay. That makes sense.
That's something. And sometimes, I've had students that came from an outpatient and a neurovestibular standpoint. They did really well, obviously, with vestibular patients. I've had students that have come from, an outpatient or an orthopedic rotation is what I meant. Sorry. Orthopedic rotation. And let's say, a wound care focused environment. So they've had maybe brought different skill sets to the picture, or, I've had some that had, 2 orthopedic rotations prior to, and they do really well with the evaluation and treatment of all of the orthopedic diagnoses that we come across. So I think, but at least what I find is the majority of your patients are that in that musculoskeletal orthopedic realm. not all, but the majority, that a strong skill set for evaluating orthopedic injuries is critical. Because what I always tell students when they come in is, I said, trust me, you look at child study, right? Trust me, you come into this environment better at this than everyone else here. You do. You come in better already. So just know it's just you're going to have to adapt to the acuity and kind of the chaotic nature, but the skill set you possess already is above what is being offered these patients right now. So have confidence in what you've been taught and what you can do.
Yes, that you're really well prepared. I like that.
Definitely.
All right, it's time. Are you ready for the case? Or admitted or not case?
It's hard to pick one, but I had a patient who had taken a fall at the Grand Canyon, which is about 90 miles from here. And they had fallen forward and struck their head, had a laceration on their orbit, and was complaining of some neck pain. They had some plain films that were normal. And when I went in to do the evaluation, the patient was just said, it just feels like something's not right. It feels, are you sure my neck's not broken? That's what they said to me. And, immediately you go, well, patients.
It's a red flag.
Bodies, it's a total red flag. But negative x-rays, right? And so we talked through that a little bit, and they ended up because of the facial that they had, they ended up doing a CT scan, like a max face CT scan, and they caught a C1 fracture.
Ooh.
CT scan.
How much of an exam did you do before that?
I did a distal neurologic exam, and because of the timing actually was to my benefit, because I didn't do any kind of palpatory exam. I didn't do any type of, I actually didn't even do range of motion initially. I wanted to make sure everything was clear neurologically. Mm-hmm. And then I actually stepped out and was talking to the physician about that. And they were like, well, we have a max face, ordered, just hang and wait. And so we waited for that. And then they saw that as a incidental finding.
That's fascinating.
Incidental.
I've been reading a lot about the reliability and validity of our upper ligamentous, cervical upper ligamentous testing to make sure things are stable, because that can fall to the physical therapist, right? Mm-hmm. So if that neck x-ray is normal, and then you go and you're doing the range of motion and the patient's like, it just doesn't feel right, but it looks okay. I would still probably, based on the trauma, do that upper cervical ligamentous testing. So I would be interested to know how that would have been.
Yeah. And I think that would have been my standard of practice as well. So had we gone further with that, just the timing of it, I think was just the way that timing played out, but definitely was a learning lesson for me and for me, it was sort of one of those listen to your patient.
Yes.
The things that definitely made sense. And I had one other one that was really interesting that I'll share really quick, if that's okay.
Of course.
So I'll ask you, admitted or not admitted on that.
Okay, I'm ready. On the last one?
On the other one, yeah.
The more I read about these types of fractures, the more confused I get, because I would say probably that patient ended up in a collar with a neurosurgical consult. Mm-hmm. But then the more I read, the fewer stabilization procedures I'm seeing for this. So I'm going to say discharged in a collar.
That's exactly what happened.
Oh.
Discharged in a collar.
Without patient follow-up, yeah?
Yeah, without patient follow-up. Non-surgical, but needed a collar for stabilization and healing and all of that kind of stuff. And I think one of the factors was the lack of neurologic deficits.
Yes. I've even seen research about patients who have neurologic deficits, but they're intermittent deficits, or they're clearly deficits, but they're being categorized as not severe enough to make the risks of the procedure worth it. Just fascinating to me.
Yeah, definitely. We are definitely seeing more of that. I'll share one other quick one if you'd like.
Please.
So I had a gentleman who had fallen off a mountain bike. That's mountain biking very popular up here, as it is in Colorado.
Yeah.
There's lots of good mountain bike trails. And a gentleman had come off his bike and was complaining of shoulder pain, and had plain films that were negative. And so the physician asked me to go take a look at him, which would be a very normal process. And so I went in, and the guy was diaphoretic and just did not look well. And as we're going through an exam, his neck was clean, cleared his neck. And then we were looking at a shoulder exam. And I mean, he was blocked. Like, I could not passively move him into any external rotation. I really couldn't move him much past about 20 degrees in flexion or abduction. I couldn't move him at all. And I went back to the physician and I was like, I know your x-rays were negative, but something's not right. This is not, he is certainly presents as though there's a fracture there somewhere.
Yes.
Blocked. So I'm wondering, is there, could we do an axillary view x-ray? Could we do a different type of x-ray that might show a different view? And so they did an axillary x-ray, and he had actually fractured the head of the humerus in a way that when you looked at it on plain film, you couldn't see it at all. But in the axillary, the posterior portion of that fracture was actually just outside the joint. So it was like he was dislocated. The fracture piece was dislocated outside of the joint. So it was again one of those things where, okay, plain film x-rays aren't everything, and you really have to trust the clinical exam and kind of take it one more step in.
So you really got a hard end feel.
Yes.
I love that. It's so hard to explain that to students sometimes, like what a hard end feel is where it should not be.
Yeah. It was like, that's not going anywhere. That's like hitting a cement wall.
And do you order imaging in Arizona?
It's interesting that you say that, because we just recently had some legislative change that opened that door for us. That was just in this last year. And I would say Brian Smits and our leadership at APTA Arizona has kind of led the charge in that regard, and has done some amazing things. I don't know that we've seen that trickle down so much to practice environment, certainly not in the ED. I think that what I see is that in our environment, I think because of the collaboration and the collaboration that we formed with the emergency physicians, I think they really put a lot of stock in the findings of our clinical exams. So you say, he doesn't need an MRI. This is, this is stable neurologic. They don't do it. If we say something's not right there, they listen and they investigate further. So. So I feel like, in the environment where I practice, one of the reasons why I love this environment so much, that it's such a collaborative team effort for the patient that I feel like in this environment, it probably would change significantly how I practice. But I think in a lot of other practices, that might be there would be great value in
totally agree
to order imaging for sure.
Well, any last thoughts from you today on emergency physical therapist
practice?
Oh
gosh, see, I could talk about this forever.
Same.
Anything. Yeah. I just encourage, anyone who's listening to this, that's even thinking about it. Just know that if you're a student, or even if you're an experienced practitioner, you bring value to the ED environment, no matter what practice setting you've had or lack thereof. You bring value, you bring a unique perspective to an emergency department practice, and patients absolutely love the interactions that they have with physical therapy. Even if we're able to change their pain, even in some small fashion, you have sold them on physical therapy for So I would say, it's a real goal. I listened to Sarah Neckbot will talk about their coalition in Wisconsin that's trying to really push for physical therapy in all ERs and urgent cares. And I couldn't agree more. I think in any environment where people are coming in with urgent or emergent problems, that there's value. There's value for having physical therapy in that environment. So get in there. Let's put a PT in every ER.
Let's do it.
Yeah, every ER.
Well, thank you so much for being with us today, and thank you for all the work that you've done to make this a thriving practice area.
Well, thanks for having me. I've really appreciated this opportunity, and hopefully we'll continue to see more coming.
Love it. Thanks so much, Lisa.
All right. Thanks.